Today we're talking with Vickie Zamora, the Clinical Director of Occupational Therapy at Carpe Diem Academy. Welcome to Smartlife, Vickie. It's great to have you.
Welcome to Smartlife, Vickie.
Thank you so much. Thank you for having me.
So Vickie, what exactly is occupational therapy?
Occupational therapy functions in different settings. For example, my profession has been in pediatrics for the last 8 years, but occupational therapy also exists in other settings like in hospitals, skilled nursing facilities, or geriatrics. So within the pediatric field, I work a lot with fine motor skills. So these are the skills of holding a pencil, being able to manipulate small objects, and dexterity. So opening and closing a button, a zipper, manipulating a lunchbox, maybe. Tying your shoe is the big one, and all the skills that fall under that. So aside from just the fine motor skills, I also work on self-care skills, which include the buttoning and the shoe tying, but it also involves executive functioning and cognitive skills. So what that means are the higher level thinking skills that you need to sequence a task or to use deductive reasoning to figure out how to solve a problem. I also work on social skills and pragmatics of children understanding rules of a game, playing with one another in reciprocal play, taking turns with each other, among other things that fall within the occupational therapy field in pediatrics.
So what age do you normally start?
Within the school system, we can service children in VPK, so 3 and 4 year olds, but there's also early intervention, which is from birth to 3 year olds.
Wow, birth.
Birth.
You can start as early as birth.
Yes. The youngest patient I ever treated was 10 days old.
Wow. And what are you doing at 10 days old?
At 10 days old, it was more parent education and teaching them how to facilitate, hold the baby, how to position the baby properly. There are some children that when they're born have complications and they need to have proper positioning for breathing or proper positioning for feeding. That, of course, we interact a lot with other colleagues in other disciplines like speech therapy in those stages when they're very, very young. But we also collaborate with the professionals throughout the child's lifetime or the individual's lifetime, not to just limit it to children. So speech therapy, physical therapy, applied behavior analytics as well.
Vickie, what's the disability that you work most with? What do you find that you're kind of more involved with, or the patients need help with?
At this moment in the school system, majority of our caseload is the autism spectrum population. We do have a few children that are diagnosed with Down syndrome, and we do have a few children that have genetic abnormalities. So these are just genetic disorders that result in specific disabilities or comorbidities.
You know, there's a lot of people, including myself, maybe they'll confuse between occupational therapy and physical therapy. Right? I mean, I'm sure you get that all the time.
Which I did ask you before we hit on the air, so...
Can you differentiate? Thanks.
So, again, within the scope of pediatrics, in early intervention, OT and PT, we meld. We have very many areas that overlap, and that's okay, because it means that the occupationalists will have a certain eye to look at your child in one way, and the physical therapist will look at the child in another way. Generally, you can say that a physical therapist will look more at muscle strengthening, they'll look more at gait training, at balance and equilibrium, at endurance. Whereas as an occupational therapist, I'm going to look at it more to say, okay, what is your ability to functionally complete a task? Is the child able to move from, let's say, the table to the floor and be able to play with blocks? Can they get back up from the floor? If they have a crayon, can they hold it properly? Can they imitate? Can they follow directions from the teacher? You know, so these are different aspects that I work with within pediatrics to separate OT and PT. You won't usually have a physical therapist work on handwriting. You won't have a physical therapist work on reciprocal play and taking turns.
That's an occupational therapist.
That would fall more under occupational therapy.
Okay. It's more like a narrow cast, more of a niche type of thing. If the child can't stand up, maybe the physical therapist helps them stand up, but at the time, you help them how to write, and how to hold a pencil. Okay.
So the physical therapist may focus on the muscles needed to be able to teach that child, or for that child to have the strength to stand or to walk. But then I'm going to try and say, okay, can you walk to the sink and stand there long enough to brush your teeth?
Okay.
And you know, what adaptations do I need to do for that?
So that means a physical therapist and occupational therapist, their education is pretty different.
Correct. There are areas, like I say, that will mingle, but at this moment, occupational therapy is a master's level degree and physical therapy is a doctoral level degree. And currently, occupational therapy is making the transition in the future towards the doctoral entry level.
Okay, so then you have to go back to school, or?
Thankfully, no. I've invested a lot of time and money into my profession, and fortunately, I can continue to practice with my master's degree. All new entry-level therapists, as of, I believe it's 2022 or 2021, may be required to have a doctoral for entry-level work.
Now for infants, when you work with infants, we talked about they can start as early as birth, but what skills are you using for them, and what are they really learning?
Personally, I haven't worked with an infant in quite some time, but when I did, the things that you're working on is, like I mentioned before, parent education, for them to understand what are the needs of their child and what positioning they need to do. But also some things that we do is, for example, eye development. There's little stickers that we put on the side of the little crib, for example, let's say a cat and a dog, and they're high contrast, which means that they're black and white images. And the whole purpose of that is when you have baby laying on their back and they're over here and they're like, oh, that's something there. And then they turn, oh, that's something else over there. So now you're strengthening their neck just by getting them to look at something interesting. You're strengthening the muscles of the eyes because they're trying to focus. Mind you, you're a baby in a crib, the wall's right here and the wall's right here. So it's here, this is your life. This is your life. And when you hear therapists talk about tummy time, it's huge. Why? Because when the baby's on your chest, or when you have baby on the sofa next to you or on the floor and they're on tummy time, yes, they're going to cry. I hear so many times.
I know, I tell this to parents too, it's okay.
Because that is baby CrossFit. They're on their tummies and they're crying and they're turning their head. They got to lift and turn.
And why they cry, they're strengthening. So it's working.
They're strengthening.
Exactly.
Then they get strong enough to like push up, and now they're doing baby push-ups. So that chest, these shoulders are getting stronger, and now they're like, oh, there's something over there and over there.
Right. Eventually, you'll stop crying.
Mommy will say, I'm getting your milk ready from the kitchen. Oh, that's mom's voice. You know, so it's all this awareness that's going on that if you hold them, oh, poor baby, you just took away that entire experience.
Right.
That entire development of awareness has been eliminated.
Vickie, as far as with children are concerned, where do these sessions take place? This therapy, where does it happen? Where do you go?
Occupational therapy within children can happen at their home if they receive home health services. It can happen inpatient in a hospital. It can happen in an outpatient clinic. We can work in the school systems, whether it be a private school, a charter school, or a public school with the Department of Education. There are even some therapists that go to camps, and they'll follow the child and go to camp. And if that's allowed, if the camp allows it, we follow them and we do it there.
And if the insurance allows it too, I'm sure, right?
Correct.
That's
so we really are only limited by asking and verifying, is it okay? Can we do it? Do you want the service? Do we go to the house? Do you come to us? You know, we do our best to try and work with the parent because parent involvement is so crucial for functional carryover and positive carryover. Because if we're teaching the child a strategy and we don't teach it to mom and dad or grandma and grandpa, how do we know that after Monday through Friday's done that it's going to be carried over Saturday, Sunday, or even think about winter break, spring break, summer break. So families
you
go
don't
on
have
vacation.
to fall behind in their therapy.
That work continues.
Exactly.
Almost when you're doing PT as well, you just can't. You have to work at home as well and get your muscles.
And even when you're discharged from physical therapy, 9 times out of 10, they're going to give you home exercise programs. They're going to give you homework and say, continue this. Just like everybody should have a healthy routine.
Do your homework.
Absolutely. Vickie, it's been a pleasure having you.
Thank you, Vickie.
Thank you so much.
Appreciate it.